And here is your question. Right, so if you have read and understood, considering the history-taking session, kindly begin.
Okay. Hello, my name is Dr. Memona and I'm one of the exam candidate today. Can I confirm your name and age, please?
Hello, my name is John. I am 56 years old.
Nice to see you, John, today. So today I have been asked to take history regarding your medical. For that reason, I have to ask few questions from you. Is that okay with you?
Okay.
Thank you for so much. So tell me, how can
I have a lump in my neck.
Oh, so sorry to hear that. So, Mr. May, when you first noticed that lump,
It is about 2 months ago.
okay, so the gradual or it is increased suddenly?
It will start gradually.
Okay, so does it stays there or is it comes and goes?
It is just there all of the time.
Okay, so sorry to hear that. So, Mr. John, tell me, is there anything which make it worse?
No,
Okay, and anything decreases the size of the lump? Like, did you notice anything about
No.
food, any other medication?
no, nothing.
Okay, so Mr. John, did you notice any changes in your voice recently?
Yes, my voice has just become deeper.
Okay, and what about snoring? Did your partner told you about the recent changes?
No, I have noticed.
Okay, do you have any difficulty in eating food?
Yes, I have some like discomfort while swallowing.
With the solid food or also with the liquid diet as well?
It is with the solid.
Okay, sorry to hear that. So, Mr. John, tell me about your weight. Is it the same?
I have lost 2 kilograms.
Okay. Are you doing?
It is unintentional.
Okay, and tell me about diet.
I don't feel like I have desire like I used to before.
Okay, so Mr. John, do you have any kind of fever recently or any cough along with this
No.
lump?
No fever, no cough.
Do you feel any pain as well?
No,
Okay, and what about any chest pain or any kind of, wheezing, difficulty in breathing?
no, I don't have.
Okay, and did you visit any Asian countries recently or any tropical countries?
No,
Okay, Mr. John, if you don't mind, can I ask you some personal question as well?
okay.
Okay, do you visit your GP on a regular basis for other medical conditions?
Yes, I have been hypertensive for about 5 years ago.
Okay, and for what medication do you take for this?
I don't know what is exactly, but I just take pills one per
Okay,
day.
okay, no worries. We will find out later on. So, do you ever went any kind of surgeries?
No,
Okay, do your family has this kind of problems?
no, no one.
Okay, Okay. Let's ask some question about your personal history. What you do for your for living?
I'm a farmer.
Okay, that's nice. So, to whom you live with at home?
I live with my wife and my children.
Okay, that's nice. So, do you have any difficulty in, in the joint movement or any moving in the stairs?
No.
Do you smoke?
Yes, I smoke
And how many packs per day?
about 2 packs per day.
Okay, and what about alcohol intake?
No, I don't drink alcohol.
Okay. Okay, that's nice. So, Mr. John, can you please tell me what you suspect the cause of your disease?
Concern that is my answer, is it?
At the point, it's very early to say it's a cancer. We will definitely do some investigations and we will rule out the cause. So,
Okay.
at this point, we are not sure is it the cancer or any other disease. Okay. But you
Okay.
don't need to be worried about. We will definitely do some workup to check it. Okay.
Okay.
So what is your main concern?
Just my concern that might be something that's not good, like said cancer or something. It's not benign.
Okay. So Mr. John, do you have any kind of epigastric burning, or do you feel like acidity coming from your back of your mouth? Do you feel like that?
No.
After food intake? Okay, what about the tummy aches or any joint pain or back pain?
No, I don't have.
Okay, do you have any difficulty in passing urine or stool?
No.
Okay, that's really nice. Is there
Can you
anything you want
present-
to add in this history?
Good. Can you present your history now?
Thank you so much, Mr. John.
Thank you.
Okay, Mr. John, a 56-year-old male, presented with a 2-month history of unilateral enlargement of the tonsil, and there is a history of the 2 months history of the there is a there is a history loss of 2 kgs in the last in the recent months, and also decreased appetite. The lump increased gradually, and it's not associated with the fever or cough, any chest infection, and
And increasing
on the
discomfort and swelling. Okay.
yes,
Yes. What are your differential diagnosis for this patient?
okay, on the basis of history, my first provisional diagnosis is tonsillar cancer.
Okay.
It might be of the, yes. Secondly, it might be tonsillitis infection,
Okay. Third,
and
could be
it might
lymphoma,
be
could be
a
tuberculosis. Okay. How would you
yes.
confirm your diagnosis?
For the definitive diagnosis, I will do tonsillectomy and I will send for the biopsy.
And any other?
And for I will do some blood investigations, just rule out differentials. Like I will do I will check and do the blood total blood CP to check that TLC count for the infection. And I will do LFTs, RFTs, just to check oral intake is normal or decreased or is affecting the renal function, and for any kind of the metastasis.
What
And
are the
I will also
alternatives that you can offer to this patient?
For the I will do the CT scanning for the stages, and if it's turned to be carcinoma, then we will do then I will do the radiotherapy first, and then I will go for the tonsillectomy out of the nodal excision, neck dissection, the lymph nodes.
Yes, you'll discuss it in MDT and then you'll go ahead and you'll do the management. Right. Good. Thank you. So, Dr. Mohammed, can you give the feedback first? It was quite,
Okay.
yes, good.
She was quite confident and
Yes.
she has clear voice.
Mm.
I think she missed some point, like she didn't ask me about asymmetrical enlargement.
Yes.
Also, she didn't ask me point to the site of the swelling. I said
Yes.
I have a neck swelling. It's from inside or outside.
Yeah.
And also, she forgot to ask about night fever, sweating,
Yes.
Hodgkin lymphoma.
Yes.
Yes.
As tuberculosis can be, or lymphoma can be one of the differentials.
Yes, and for this, she didn't ask about rapid enlargement of the lump. It's a rapid
Yes.
increase in size. So
I think she asked you
Sorry.
it has developed overnight or gradually. You said gradually.
Yeah. You said it's
if it is
gradually increased.
rapidly increasing in size.
Okay,
Yes.
now if it's rapidly increasing, all right. Okay, yes. Anything else that she has missed?
For the investigation, did she mention monospot test for glandular fever?
No.
Yes.
She
Okay.
forgot that.
Just that's my comment. Thank you.
Yeah, good.
Thank you
Thanks.
so much.
Anyone else want to add anything?
Ma'am, I would like to ask some which sir has just mentioned, is monospot test needs to be done?
In investigation, yes, to rule out glandular fever.
Okay. And as for the neck dissection, should we have to just mention neck dissection or we have to specifically say radical dissection, modified or selective? Which one?
Right.
And
He wants.
CT,
Because someone has written it in the chat, radical slash modified
Yes.
slash selective.
The Dr. Karma will talk. Yes. Once you have done CT, you have already to rule out CT or MRI for the staging, and then you'll discuss in MDT, and then you'll do the. You can say neck dissection of this or block neck dissection they are talking about. Yeah. Yes. Dr. Karma, you wanted to add something?
Yes, thank you, ma'am. Thank you, Dr. Memona. It was very nice. You covered most of the things,
Yes.
and you were almost timely.
Yeah.
Few like comments I would like to add. When you were asking few questions, like you were like directly asking, like, tell me, like you use this, tell me word 3 times. So I found maybe that could sound rude. Like, can you please tell me? If you can use like that. You said, tell me about your appetite. Tell me about something. I think you use it 3 times. Then maybe, I mean, when he mentioned about his job that he's a farmer, you were saying that's nice. You used that's nice 3 times. I don't know what's nice about that. Maybe like you could use something else, some other words, okay, or just say okay. Then another thing, I think you missed the expectations.
Yeah, expectation she missed.
Expectation.
Yeah.
You asked about the concern, but you missed the expectation.
Idea and concern she asked, and expectation
Yeah.
she admitted, yes.
And the rest, I
ma'am,
think.
actually, he told me, sorry to interrupt. He told me in the, he already told about the expectation. So I thought like I should not ask it again.
Okay.
Yeah.
Yeah, these are my few comments. Thank you.
Right, good. Thank you.
Thank you.
Here is your question. Right. So if you have read and understood, considering the clinical examination patient, kindly begin.
Yes, ma'am. Good morning. I'm Kumar, one of the exam candidate. Can you confirm your name and date of birth, please?
I'm Smith, 72 years old. Yes, continue.
Hi, Mr. Smith. Nice to meet you today. And I'll wash my hands. Today, I've been asked to examine your lower limbs, and it will involve looking at it
Patient does not
and
know lower limbs, maybe legs, you can say.
yeah, looking at the legs, and it will involve looking at it and looking from sides or looking from front and feeling for the different pulses in the leg and listening to your legs and abdomen. And is that okay with you?
Yes.
And do you have any pain? Do you have any pain anywhere at all before we start?
No, not much. Continue, please.
Okay, thank you. So we'll begin by examining the hands. So I'll tell the patient to stretch the hands. Then I'll start looking at the hands. First, I'll look at the skin for any shiny skin or hair loss, and I'll see the nails. I'll see the muscle wasting, and I'll see the nails for nail fold infarcts, and I'll see for the splinter hemorrhages. Then I'll see for the nicotine staining, and next I'll go and see for the pulp of the fingers, see for the any atrophy of the pulse of the hand, and I'll press the hand for capillary refilling time. Then I'll check for the pulsations in the radial pulsations in both the hands and compare. Then I'll tell him, like, I'll go, then I'll start looking at your legs. And so I'll look at the legs by starters at the skin. So I'll look at the skin, whether it is shiny, stretchy, and whether any hair loss present. And I'll look at the nails for splinter hemorrhages. And is there and I'll look at the pulp of the toes for any atrophy. And I'll look at the interdigital clefts between the toes for any ulcer, and I'll look at the sole of the foot. Then I'll look at the legs for any scars of previous surgery, looks for signs of chronic insufficiency, like any color changes, like black or discoloration of the skin. And I'll look for the any ulcers or the medial aspect or the foot or the metatarsal heads. Then I'll look for any deformities in the legs, foot, like claw toes or pescavus or anything. Then I'll look for any gangrene or amputations. Then I'll start palpating. So I'll start by temperature from distal to proximal. Then I'll start compare on both the legs. Then I'll start doing the capillary refilling time in the toes. Then I'll start the Burgers angle and test. Here I'll make the patient lie down, and I'll tell him, before lifting the leg, I'll tell him, is there any pain in your hip? If there is no pain, I'll start doing the elevation of the leg, and every 10 seconds I'll elevate every 10 degrees, and I'll stop when the leg turns pale. And I'll if leg then I'll tell him sit from lying down position, and I'll see for the color change in the legs. And then feeling for the pulsations, I'll feel for the femoral, popliteal, dorsalis, and posterior tibial. Then I'll start measure. If pulsations are felt, then fine. Or if it is feeble, I'll compare on the both sides. And if at all, if I can't feel it, then I'll use a Doppler to locate for the pulsations. Then I'll start doing the auscultation. I'll hear the aortic and the iliac bruit just above the inguinal region, and femoral bruit in the mid-inguinal point. Then I'll start calculating the ankle brachial pressure index here I'll calculate the lower limb pressure, then the upper limb pressure, and I'll divide both. Then that will give me the ankle brachial pressure index. So then
We'll pick the Doppler and
Doppler, then I'll calculate the ABPI, and then that's all, ma'am. Then I'll tell the patient to help him to redress himself. Then I'll tell thank you. Then I'll wash my hands.
yes. All right. Okay. Can you, few seconds are left, but can you summarize your examination?
So today I have examined Miss Smith on inspection. Should tell normal findings, ma'am, or
Tell me what you expect to find considering the scan.
okay. I've examined Mr. Smith on inspection. There is skin is shiny, and there is hair loss present, and the color of his legs are pale, and he's got a loss of toe, one of the toes, and then he has thickening of the nails. Then any ulcers or no gangrene seen, and on palpation he has a increased temperature on the right side. Then there is feeble pulsations present on both sides of his distal pulses, dorsalis pedis and posterior tibial. And I did Burgers test on him. It shows the leg turns pale on right side at 25 degrees, and then I made him to sit. Then the leg changes from pale color to the red color, and then the capillary filling time is more than 4 seconds. Then
So what are
I
your
did the
differential?
Doppler
Yes,
since.
yes, Doppler finding were.
So Doppler finding, I did the Doppler finding because there was feeble pulsations. Then it showed
Could
a
you hear the
monophasic
pulses?
flow in the.
On Doppler finding, could you hear the pulses? This is you have to tell me.
Yes.
All
It
right.
was
So what are your,
monophasic.
yes, what are your differential diagnoses?
So my differential diagnosis will be a peripheral vascular disease, probably due to diabetes or atherosclerosis.
What
And
other, okay, what other differentials would you consider? How would you
so can
confirm
be
your
peripheral
diagnosis? Yes. Peripheral neurovascular,
and
okay.
neurovascular.
So,
Then I would like to do.
yes.
I would like to do a complete vascular examination of the upper limb, cardiovascular examination, then neurological examination of upper and lower limbs. Then I'll do the investigations. Start with baseline investigation like full blood count, urea and electrolytes, blood glucose, blood cholesterol, and then
What are the treatment alternatives that you can offer to this patient?
So I'll start controlling his blood sugar, cholesterol, and dietary control, and then I'll do if the vessel can be stentable, then I'll do the vascular stent or the bypass, or if it is not, then a palliative measure.
Okay. What is the palliative measure that you can
Then,
offer? What is
so
the
if at all, if there
yes.
is if there is complete blockage and think he may need amputation, if any complications arises. Otherwise, I try to do a stenting or the bypass to increase the blood flow to the legs.
Okay, if patient refuses surgical management, then what is the conservative treatment that you can offer to the patient?
Mm,
Lifestyle modification, lifestyle changes,
yes,
and
ma'am.
anything else?
Mm,
Patient is diabetic, maybe you'll advise the patient to meet a dietitian and control the diabetes.
yeah, ma'am.
But
Control the diabetes, control the blood pressure, control the blood cholesterol. And so he may need anti-lipid lowering agents and anti-diabetic medications and diabetic medications.
yes, so right.
Thank you.
Thank you so much. Bell went. You took little extra time, but it was your first time with us, so yes,
Yeah, ma'am.
cessation of smoking. Anyone want to give feedback to Dr. Santosh? I just feel when you entered, you introduced yourself. Okay, you confirm patient's identity, but then you didn't instruct the patient what to expose. So exposure you missed.
Expose I didn't do. Yeah,
Yes.
I
So
did from abdomen. Yeah.
yeah, you didn't ask the patient to expose itself. And then when you were examining, okay, you did cover everything, but the way you were presenting, you were thinking a lot. Could be because it's the first time and you're new, so that I can ignore. But then when I asked you for differential diagnosis, then my request is that everyone should come up with 3 to 4 differential diagnoses. One is the primary provisional diagnosis, that should be number 1. Then 2, 3,
Okay.
and 4 should be the differential diagnosis that you are, once you're examining the patient, you have to rule them out. So otherwise there's no point examining a patient until or unless you're ruling out the conditions, and that
So,
examiner should know as
okay.
well.
Okay, ma'am.
Yes. Right. Anyone else want to include anything?
Ma'am, there is one question. Can I ask?
Yes, please.
Yeah, madam, like in this case, we have done the peripheral vascular examination, but we
Yes.
haven't done neurological examination.
No.
So is it possible we can root neurological conditions, but they will be in our differential diagnosis?
Yes. How would you do that? First of all, in this one, you have to calculate ABPI. Whereas if it is for it was neurological patient, then first of all, there'll be ABPI will be mentioned, patient will be sent by the GP. And in the examination table, there'll be hammer, cotton, and neurotape for measurement. Here it will be a Doppler, so you know it's a vascular examination. So how would you confirm, like once you're examining the patient, then this is the basic thing that you get to know, that you have to calculate ABPI and it's the vascular, not the neurological. Then once you're doing the different tests, like your Berger's test and the femoral, the pulses and the capillary field, then you can also rule it out that once you're doing this and you're calculating the ABPI, so it's not the neurological.
And these patients will be real patients, no, ma'am?
Yes,
in this
real
peripheral
patients.
vascular disease, if they are
Yes.
keeping actors, these patients won't come.
No.
If they are keeping the real patients, then this
Only.
patient,
Yes.
this will
Yes.
come.
Definitely. Yes, good. Thank you. And here is your question. Your question. Right, so if you have read and understood considering this surgical anatomy patient, kindly tell me if you can identify the structures. Can you please explain the view that you're looking at right now?
Yes, ma'am. This is a prosected image of the thoracic cavity showing the mediastinum. This is a sagittal view.
Okay, how is mediastinum divided or how is it classified?
The mediastinum is divided into superior and inferior mediastinum primarily
Yes,
by
yes.
the plane of Lewis, which is a line drawn from the angle of Lewis to the fourth thoracic vertebra. And the
Anteriorly it
inferior
is,
mediastinum is
anteriorly it corresponds to what level? Angle of Lewis is
T4 level.
yeah,
Uh,
or
uh,
T4 is at the back, disc between T4 and T5. In front, it is second costal cartilage.
Yes, ma'am. Second
Yes.
costal cartilage.
Okay, yes. Then further classification or division.
Yes, ma'am. The inferior mediastinum is further divided into the anterior, medial, and posterior mediastinum by the
Yes.
fibrous pericardium.
Yes. All right. Good. Can you tell me the boundaries of posterior mediastinum?
Yes, ma'am. The posterior mediastinum is bounded anteriorly by the pericardium and the vertical diaphragm. Posteriorly, it is bounded by the 4th to 12th thoracic vertebra, and laterally there is the pleura. The roof is formed by the angle of plane of Lewis, and the floor is formed by the diaphragm.
Very good. What are the contents of posterior mediastinum?
It contains the descending thoracic aorta, the azygous and the hemizygous veins,
Yes.
the right and left vagus nerves, the right and left splanchnic nerves. It also contains the esophagus, thoracic duct, and the thoracic sympathetic chain.
Yes. And esophageal plexus, posterior mediastinal lymph nodes.
Yes, also lymph nodes and
Yes. Can you
esophageal.
identify the structure which is pointing with this red arrow, please?
Yes, ma'am. That is the thoracic cervical sympathetic.
Yes. Can you please tell me the course
That
of
is
the
the thoracic
sympathetic?
sympathetic chain.
Yes. Can you please tell me the course of the sympathetic trunk or the sympathetic chain?
So the sympathetic trunk is from the T1 to L3. They lie laterally to the vertebral column on each side.
Yes. Can you please tell me? Yes. Yes.
The thoracic is a continuation of the cervical sympathetic trunk. So there is a ganglion at the superior part, which is the stellate ganglion.
Yes.
And at the end of the sympathetic trunk, they fuse to form the ganglion implant.
All right, good. Can you tell me how is it connected to the spinal nerves?
They are connected by preganglionic white ramus communicants and postganglionic gray ramus communicants.
Yes, good. So can you tell me how this sympathetic chain or sympathetic nerve leaves the sympathetic chain?
They leave the sympathetic chain through the spinal nerves and the plexus formed around the vessels and the pulmonary plexus, the celiac plexus.
Okay. Can you please identify if there is, okay, what is this 3 pointing at?
And these are the branches from the sympathetic trunk to the splanchnic nerves.
All right. Right. How did you say they form plexus and then they leave around the blood vessels and then they leave?
They leave through the spinal nerves and the plexus around the major vessels.
How many plexus there are in the posterior mediastinum or in the thorax, if you can tell me?
So ma'am, there is the esophageal plexus, the pulmonary plexus, the cardiac plexus.
Yes. Then greater splanchnic and lesser splanchnic. Okay.
Greater
Right.
splanchnic and lesser splanchnic.
Can you identify this number 1 over here?
Ma'am, that is the arch of the azygous vein, which is joining the superior vena cava.
Can you tell me, please, the tributaries of azygous vein?
The tributaries of azygous vein are the pericardial veins, the esophageal veins, the bronchial veins, then right superior intercostal veins, and right lower posterior intercostal veins. Yes, and these are tributaries.
Hemiazygous and excess to hemiazygous vein
Yes, ma'am.
and
Also hemiazygous.
pericardial veins. I think you mentioned those.
Yes.
Low right posterior intercostal veins. Okay, right, good. Can you please identify the structures in this one? All the labeled. Number 1. Yes, please. If you can identify what, yes, can you please tell what is 1? If you can tell me 2 is?
I'm on my phone and I can't like zoom the image. It is very blurred.
Okay. All right. If you can just tell me what are the contents of anterior and middle mediastinum. Contents of anterior and middle mediastinum, if you can just tell me, please.
In the anterior mediastinum, there are the remains of the thymus gland and the branches of the internal thoracic artery. In the middle mediastinum, there is the pericardium, which contains the heart, the superior vena cava, the arch of aorta, and the bifurcation of trachea, the pulmonary arteries and veins, and the phrenic nerves. And the posterior mediastinum, ma'am, there is the descending aorta.
Yeah, that you already told me.
Okay, yes, ma'am.
Right. Okay. What more we can ask you? I have kind of asked you everything, but then you can't tell the.
Yes, from the image, I'll try to
Image.
log in from my
Yeah.
computer. Yes.
That's all right. Can anyone else help? We can just few seconds are left for the bell, but then we can identify. Dr. Snail, can you please?
Yes, ma'am. Good evening, ma'am.
Good evening.
Yes, ma'am. Number 1 is, ma'am, esophageal impression.
Who is
6, 5,
esophagus? See, there is how
One
there
is
Trachea.
trachea.
trachea,
Yes. And
2 is esophagus.
2 is esophagus.
Okay.
What is 3, please?
Yes, ma'am. Right atrium.
Yes.
7 is, yes, ma'am, left atrium. 5th is the this is the aorta, ascending the aortic side wall, and the 6th
Yeah,
is ascending.
Yeah.
Yes,
6
ma'am.
is
4th is the, yes, 4th is ventricle.
Yes.
Mm.
And 7, you told me 8. Liver.
Yes,
9.
Diaphragm.
diaphragm. Yes, ma'am.
10. Where is 10? Yes. Here.
Manubrium.
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 What is A? It's
Sternum.
Fine,
junction
ma'am.
angle of
What?
Lewis. Yes.
Yes, ma'am.
11.
That is the body of the sternum, ma'am.
Yes. Good. So that's it. Right.
What's the 6 on listed?
What is 6, Dr. Snell?
Yes, it
This
is
is
Column
aortic
from-
cusp, aortic cusp, and then this is what? The
it is
outflow tract.
ascending.
Yes.
Aorta.
Yes.
Yes.
7 is, I think, pulmonary artery, no, ma'am?
Yeah.
Right.
No,
This
ma'am
is
said
from-
7 is left atrium.
This is from Dr. Exam book.
Ma'am, I
7
have
doesn't
that.
look like an atrium.
Ma'am, I
Yeah.
have that doctor example.
Yes, even I have it. I'm trying to find it so that I can tell you exactly. And here is your question. Right. So if you have read and understood, considering this surgical and augmentation, kindly tell me what are you looking at? If you can tell me how to
Yes, ma'am.
classify the triangles of the neck, please.
Yes, ma'am, I'm looking at the image showing triangles of the neck on the left
Yes.
side.
Yes.
The triangles of the neck are mainly classified as anterior and posterior triangle.
Yes.
The anterior triangle is bounded by anteriorly midline of the neck, posteriorly by anterior margin of sternocleidomastoid, and
Yes.
superiorly by lower border of the mandible and line joining the angle of mandible and the mastoid process.
Yes.
A
Good.
posterior triangle is by posterior margin of sternocleidomastoid, anterior margin of trapezius, and below it is formed by the middle third of the clavicle. The roof is formed by investing layer of deep cervical fascia, and floor is formed by prevertebral fascia. Anterior triangle is again subdivided into 4 triangles
Yes.
by anterior and posterior belly of digastric and the superior belly of omohyoid muscle.
Yes.
The submental triangle, submandibular or digastric triangle, upper carotid and lower muscular triangle. And submental triangle is formed by the anterior margin of the anterior belly of digastric muscle and hyoid bone below, and
Yes.
anteriorly by the midline. Between the anterior and posterior belly of digastric muscle, there is submandibular triangle. And above the superior belly of omohyoid, there is carotid triangle, and below is the muscular triangle. Posterior triangle is again subdivided into the inferior belly of omohyoid muscle into occipital and the supraclavicular triangle.
Very good. Okay. Can you please tell me the contents of the carotid triangle?
Yes, ma'am. It contains the carotid sheath
Yes.
lining the upper part of common carotid, the external carotid and its branches. Also, there is internal jugular vein and the vagus nerve along with the lymph nodes.
Okay. Would you be able to identify what each of these are? If you can identify what is one is.
Yes, ma'am. It is posterior belly of digastric muscle.
Okay. Right. What is two?
2 is, ma'am, carotid triangle.
Okay. Three, please.
3 is occipital triangle, the
Four,
posterior
please.
triangle.
Four.
4 is, yes, ma'am, it is clavicular sternal head of sternocleidomastoid.
Yes. Five, please.
5 is inferior belly of omohyoid.
Six, please.
6 is trapezius.
Seven.
It is the middle part of the clavicle, middle one third.
It's actually triangle. It's above clavicle.
Yes, ma'am. It is the supraclavicular triangle.
Yes. Eight, please.
It is muscular triangle.
9. Which muscle is this?
This is superior belly of omohyoid.
10, please.
10 is the hyoid bone.
Yes. 11, please.
11 is submental triangle.
Good. 12, please. Which muscle
12
is this?
is, yes, ma'am. It is anterior belly of digastric.
13, please.
It is submandibular triangle.
Very good. Okay. Can you please identify here? If you can identify the structures, what is A, please?
Yes, ma'am. It is superior thyroid artery.
Yes. B, please.
Yes, ma'am. It is internal thoracic artery.
C, please.
External carotid artery.
Good. D, please.
Yes, ma'am. It is left-sided brachiocephalic vein.
E.
It is isthmus of the thyroid.
Good. S.
It is right lobe of the thyroid gland.
Yes. G, please.
And G is thyroidea ima artery.
Okay. Can you please tell me the surface anatomy of spinal accessory nerve?
Yes, ma'am. Spinal accessory is nerve can surface anatomy can be described by the rule of thirds. It lies in the posterior triangle. It traverses from the upper 1/3 of the posterior margin of sternocleidomastoid to the lower 1/3 of anterior margin of trapezius muscle
Okay.
in the neck.
What is the area of supply of this nerve?
Spinal
Usually
accessory.
C2 and C3. Yes.
Yes, ma'am. It is pure motor
supplies-
nerve
Yes.
and it supplies ipsilateral trapezius and sternocleidomastoid muscle.
Yes. All right. Good. Can you please also tell me the course of external carotid artery? We identified here. See.
Yes, ma'am. External carotid artery is a branch of common carotid artery. It starts at the bifurcation of common carotid artery at the level of C6, and it ascends in the
C4.
C4.
Upper
ma'am.
border of the thyroid cartilage. Yes. Then.
Yes, C4 vertebra, and it traverses in the carotid sheath along with
Yes.
internal jugular and vagus nerves.
Yes.
And in the neck area, it gives branches such as superior thyroid artery, lingual artery, facial artery, ascending pharyngeal artery,
Yes.
and two terminal branches, maxillary and superficial temporal artery.
All right. Yes. So there. Okay. How does it ends? It divides, terminates into. What are the two terminal branches?
These are superficial temporal and maxillary artery.
Yes, behind the mandible. Okay. Can you tell me what is carotid body?
Yes, ma'am. Carotid body is a type of a baroreceptor which lies just above the bifurcation of the common carotid artery, and it contains the baroreceptors.
Yes. Okay.
These are
What is
mechanoreceptors.
carotid sinus?
It is some dilated part of the just proximal part of external carotid artery.
Yes. Can you tell me what are the
No.
okay, pre-auricular lymph node drains into, what is the region which is drained by it?
So, ma'am,
Temporal
the
region, auricle, yes, auricle and external auditory meatus and gums. Okay, can you
Yes,
please
ma'am.
identify the structures here? You can see some of the structures, their surface marking is there. So what is this red?
Yes, ma'am. It is yes, ma'am. It is external carotid artery, common carotid and external carotid
What is this
artery.
11 blue?
That is external jugular vein.
Okay. External or internal? So what is this 5?
That is anterior jugular vein.
Okay. There are certain nerves as well, yellow ones. Would you be able to identify these?
Yes, ma'am.
Arising from below the ear. Yes, please.
Yes, ma'am. Number 1 is spinal accessory nerve.
Okay.
Then number 12 is lingual. Yes, ma'am. Lingual nerve, which
Okay.
lies in proximity with the facial artery, and 15 is hypoglossal nerve,
Right. Good. Okay.
and 29 is the trunk of the brachial plexus.
Yes, behind the clavicle. Right, good. And there are certain muscles as well. Which muscle is this 13?
That is inferior belly of the omohyoid.
Thank you.
Thank you, ma'am.
The timer, and here is your question. Right, so if you have read and understood, considering the clinical examination session, kindly begin.
I'll enter the room. I'll wash my hands. Hello, I'm Dr. Karma, one of the exam candidates. Can I confirm your name and age, please?
I'm 65, I'm Tina.
Hello, Tina. Nice to meet you. So today I've been asked to examine your hands, which will involve looking, feeling, and also moving your hands. Does that sound okay with you?
Yes.
Okay, thank you. I'll expose the patient, expose her hand, forearm, shoulder, and the chest, and she can keep the waist for dignity. And then I'll also position the patient. Patient will be in propped up position with the arm rested on a pillow.
Good.
Then, Tina, I'll begin by having close look on your arms. Okay, so I'll inspect for any skin changes, any scar mark, any swelling, any the site of the swelling, the size, shape, surface, the overlying skin condition, any scar mark, and then surface. Then I'll also look for any swelling over the arm, any color change, and then any signs of venous collateralization over the shoulder and the upper chest, which would suggest deep venous, central venous obstruction.
Yes.
Now, Tina, I'm going to lift up your hand. Before that, can I confirm you have any pain at the moment in your shoulders or elbows?
No.
Okay, so I'll just lift your arm. I'll do the elevation test and see whether the swelling disappears or not. Now, Tina, I'm going to feel your hand. Okay, if you have any pain if you have any pain or discomfort when I'm feeling it, do let me know. I'll be as gentle as possible. I'll feel for the temperature with the dorsum of my hand. I'll feel for the tenderness on the arm and also on the swelling. And then I'll feel for the pulsatility. I'll feel the pulse on the swelling and also thrill. Then I'll do the skin pinch test over the swelling. And then I'll see the direction of flow by occluding proximal part of the fistula, and then see feel proximally and distally wherever the pulse is absent of fever. That is the outflow or the direction of flow. Then I will do the augmentation test. For the augmentation test, I will occlude the fistula proximally, and then I'll feel the proximal to the junction, and then I'll feel for the pulse proximal to that. And usually that if it will be increase in it will be normal increase in the outflow obstruction, and then I will feel for the radial pulse, brachial pulse, if I cannot feel that, then I will use Doppler. Then I'm going to listen with this stethoscope. I'll listen over the fistula for any bruit. Normally, there's a soft bruit heard with both the diastolic and systolic component. And if it is obstructed, proximal obstruction, then there will be high pitched and only systolic component is heard. Then I will now, Tina, I'm going to listen to your heart. I'll listen for the heart sounds, any murmur, and then I'll listen, and also I'll listen to the carotid arteries. So Tina, I'm done with my examination. You may dress now. I'll wash my hands. And
How
I'll
would you
present
confirm
my
the direction of flow?
direction of flow. I will occlude the fistula, and then I'll
with
feel
the
the pulse
tip of the
with
finger.
the finger, ma'am.
Yes.
Tip of finger, and
Yes.
where I feel proximally and distally.
Yes.
Wherever the pulse is absent, that is the direction of flow, ma'am.
All right. How would you know the thrill?
Thrill I'll feel with the palmar surface of the
Yes.
hand, ma'am.
Okay. Just making sure that you understood what you did. You still have 1 minute. So, okay.
Yes, to complete my examination, I would like to do neurovascular examination of the upper limb and then the cardiovascular examination.
Yes.
I've
Did you hear for
examined.
the murmurs?
Yes, ma'am.
Was
Yes.
validated. Okay.
Yes.
Today you examined, yes?
I examined this Tina, 65 years old lady.
Yes.
Who had on examination, I found that there is bluish discoloration of her right hand and swelling of her right hand, and there was a 2 into 3 centimeter size of swelling or fistula over the cubital fossa.
Yes.
That was
the
oval in
shape
shape.
of the oval? Okay.
Oval in shape.
Yes.
And irregular. Oval in shape. Surface was smooth.
Irregular. Okay.
And there was overlying scar.
Yes.
And there was brownish discoloration of the overlying skin.
Yes.
And
Arm
yes,
elevation
local
was?
temp. Yes, ma'am.
Arm elevation, was it positive?
Yes, arm elevation test was positive.
Yes.
And there was
palpation, yes.
On palpation, I found that
was the thrill
it was
palpable pulses?
Yes, the
Thrill.
thrill was palpable.
Okay.
And
radial pulse was it augmented?
Radial pulse was diminished, but it was heard on Doppler. And
on auscultation?
And auscultation, there was a bruit, but it was high pitched, and only systolic component was heard.
Okay. So what are your main differential diagnoses?
From my examination, I would like to consider dialysis ischemic skill syndrome as my main provisional diagnosis. I would also like to consider ischemic monomelic neuropathy as my differential.
Yes. How would you differentiate between the two conditions?
Yes, in the dialysis ischemic skill syndrome, the hands will appear pale or cyanotic. It will be cool to touch.
Yes.
And the radial pulse will be usually diminished or absent.
Yes.
And then the augmentation test in the fistula will be positive, and then there will be temporary relief of pain. And with the Doppler, the bruit will be heard, which will be high pitched, and then only systolic component is heard.
What investigations
there might
would
be
you? Yes, please.
Yes. In case of ischemic monomelic neuropathy, I'll find the presentation that may be confined to the nerves affected. There might be weakness or paralysis of the nerve involved. There might be, if it is radial nerve, there will be risk extension. Median and ulnar nerve, there might be involvement of loss of motor function of the hands. Yes, but it will be warm to touch, and the pulses will be normal, ma'am.
Yes. So what investigations would you do in addition?
Investigation of choice, I would like to go for an arterial duplex study.
And what are the treatment options or alternatives?
Yes, since I'm considering dialysis ischemic syndrome, I'll go for restriction of fistula flow through, I'll do bending or
Yes.
modulation through surgical revision.
Yes.
And also I can go for ligation of the fistula and creation of a more proximal fistula, ma'am, in the same
Yes,
or the
on the
other
same.
side.
Other side. All right. Okay. Good. So that is done. Right. Thank you. It was good. Anyone want to
My
give comment?
presentation was not good.
Yeah, because you did not compile it. Once you were doing it, you could have compiled and. But that's how you learn. Yes, Dr. Mamana, you want to add something?
Ma'am, I noticed one thing. We
Yes.
all are good in history and taking doing examination, everything, but we lack presentation.
You need
Like,
to work on it. That's why
yes.
we are doing these divisions. Because once
Other-
you present, you know where you are lacking.
Yes, ma'am. Otherwise, today and doctor was good in doing examination. All the points he included in. Yes.
Good. Good. And here is your question. Yes, considering it's surgical or augmentation, kindly tell me, what are you looking at?
It's in dissected projection showing lateral view of the neck,
Okay.
and it's right lateral view of the neck showing the dissected structures.
All right. Okay. Can you please tell me if you can identify number 34?
It's omohyoid muscle, superior belly.
Okay. Can you identify, please, 38?
38 is thyroid muscle.
Okay. Can you please identify 31 and 32 at the bottom?
31 is sternohyoid. 32 is sternothyroid muscle.
Okay. Can you please tell me how these infrahyoid muscles are organized?
They are organized in superficial and deep group. Superficial containing the omohyoid and sternohyoid, deep containing the sternothyroid and thyrohyoid.
Right. Okay. What is their nerve supply?
They are supplied by the ansa cervicalis, except thyroid, which is supplied by the C1 nerve root.
What is their mode of action?
They depress the hyoid bone and
larynx during
and
swallowing and
during
speaking.
swallowing and speaking.
Okay, can you please tell me what is behind them? What is this? What is this 40?
It is a thyroid gland.
Okay, can you tell me what are the parts of the thyroid gland?
Thyroid gland contains two lobes, right and left lobe, connected
Yes.
in midline by the isthmus. Sometimes there is an accessory pyramidal lobe present.
Can you please tell me what is the vertebral level of the thyroid cartilage?
It's C4.
Okay. Can you please tell me why thyroid moves up with deglutition or swallowing?
It's within the pretracheal fascia, and it's attached to the second and fourth tracheal ring by a Berry's ligament. And when the thyroid and thyroid cartilage move upward during deglutition or speaking, it moves upward.
Okay. Can you please tell me the blood supply of the thyroid gland?
It's supplied by superior thyroid artery,
Which is a branch of?
which is a branch of external carotid artery.
Okay.
And inferior thyroid artery, which is the branch of thyrocervical trunk.
Yes. And another 10% is supplied by
Thyroid ima artery, which arises from the either the aorta or the brachiocephalic artery.
Okay. What about the venous drainage?
It's by superior thyroid vein, middle thyroid vein, and inferior thyroid vein. Superior and middle drain into the internal jugular vein, and inferior drain into the brachiocephalic vein.
What are the lymphatic drainage of the thyroid gland, please?
It's pretracheal, prelaryngeal, paratracheal, superficial and low, deep cervical lymph nodes, and brachiocephalic lymph nodes.
Okay. Can you please tell me if a patient presents with thyroid carcinoma, what is the most common thyroid carcinoma?
It's
that
it's papillary carcinoma.
Okay. And what is the mode of spread of papillary carcinoma?
It is lymphatic spread.
Okay. Right. Any other thyroid carcinoma which also spreads via lymphatics? You can tell me about
medullary thyroid carcinoma.
Medullary carcinoma. What is the cell origin of medullary carcinoma?
It arises from parafollicular cells.
Okay. Can you please tell me if a patient presents with thyroid carcinoma and you operate on the patient, what are the common nerves which can be injured?
It's the recurrent laryngeal nerve and external laryngeal nerve.
Okay. And cervical sympathetic
and
chain
cervical
as well.
sympathetic chain.
Yes. How would the patient present if during thyroidectomy you've injured cervical sympathetic chain? How would the patient present?
The patient will present with ischemia-induced neural damage.
Neural damage. Okay. Can you please tell me the complications of thyroidectomy? You yourself decide how you will tell me.
It's immediate, which could be bleeding, and
Yes.
it could be bleeding on table, or it could be late, delayed bleeding. It could be a collection of blood in the wound bed, causing respiratory compromise to the patient. It can be hypocalcemia, and it could be nerve injury. And in case of nerve injury, it could be unilateral nerve or bilateral recurrent laryngeal nerve injury and external nerve injury, having different clinical manifestations. And later, a patient can have injury to the parathyroid gland also. And patient is later complication is patient is thyroxine dependent and is always and has to take thyroxine during his lifetime.
Good. Okay. Can you tell me, can you mention few benign conditions of thyroid gland?
Benign is, it could be adenoma, follicular adenoma.
Yes. And?
Cyst in the thyroid.
Yes. And?
And it can be inflammation, thyroiditis.
Thyroiditis. Okay, good. Yes. What management can you offer to the patient with benign lesions?
Benign lesions are usually managed depending on the etiology we are suspecting. In case of thyroiditis, we might give the patient for regarding the pain, analgesia, and if suspected that it's an autoimmune or something, we might start patients on thyroxine. Sometimes if
yes. What is thyroglossal cyst?
Thyroglossal cyst is an cyst present in the midline. It's formed when there is failure of obliteration of the path through which the thyroid tissue is formed.
How
The
can
path
you?
of
Yes.
descent.
Yes.
It's basically formed by proliferation of the epithelium down the base of the tongue through the foramen cecum, and it moves downward and loops beneath the hyoid bone. And the path regresses, and thyroid is present in its location anterior to the neck, and in the anterior neck near the thyroid cartilage. And when there is failure of the path to regress, it can result in thyroglossal cyst formation.
Yes. So what is the management of this thyroglossal?
It's usually treated surgically, doing a cyst trunk operation in which we remove the middle portion of the hyoid bone also to prevent recurrence.
Good. Nice.
Thank you.
Thank you. Here is your question. Right. So if you have read and understood, considering it history taking station, kindly begin.
Hello, I'm Dr. Muhammad, one of the exam surgical candidates. Today I have been asked to ask you some questions related to your condition. Are you okay with that?
Yes.
Thank you. May I confirm your name and age, please?
My name is Aaron. I'm 28 years old.
Nice to meet you. So what's brought you here today?
So I have this pain in my right knee since the last 3 months. That is why I have come to you, doctor.
I'm really so sorry to hear that. When did you first notice that?
So I first felt the pain 3 months ago, doctor.
3 months ago. Okay. Did it start suddenly or gradually?
Gradually.
Okay. Is there anything which makes the pain increase or stop?
Not really, doctor.
Okay. Can you point to the site of the pain, please? Is it on your right or on the left?
It's on my right knee, the upper part of my right.
Okay. Does it change throughout the day? Does it go and come?
The pain increases during the night.
Okay. Can you describe the pain for me? It is colicky or compressing in nature or aching?
Aching in nature.
Okay. Is it okay? If you would rate the pain from 1 to 10 with 10 words imaginable, how would you rate it?
6.
6. Okay. Do you want me to give you any kind of analgesic?
No, I'm okay, doctor.
Okay. How does it affect your day-to-day life?
So I have a problem going to work, doctor, because I cannot walk with that amount of pain while going to work every day.
Okay. I'm really so sorry to hear that. Okay. Do you have any history of trauma?
Yes, I do have some history of trauma. I had a road traffic accident 3 months ago, and the knee has been paining since then.
Oh, I'm sorry to hear that. Did you notice that any change in the shape of your knee?
Not really.
Okay. Does the pain is it throughout the day and increase during the night?
Yes, it does increase during the night.
Okay. Did you feel that you have stiffness in your joint at the morning?
No, doctor.
Okay. Did you experience before any giving away while walking?
No, doctor.
Okay. Did you notice that you have a change in your appetite?
Not really.
Okay. Do you have any history of loss of weight unintentionally?
No.
Okay. Do you have any diarrhea?
No.
Do you have any red painful eye?
Not really.
Okay. Do you have any joint pain or skin rash? Other than that?
No, nothing other than my right.
Okay. Do you have any pain in your tummy?
No, doctor.
Okay. Did you have any notice redness or swelling or discharge from your knee?
Initially there was some swelling when I had the injury, but not now, doctor.
Okay. Do you have see your GP for any other medical reasons?
Not really.
Okay. Do you have any back pain or pain in
No.
your leg or buttocks?
No.
Okay. Do you have underwent any surgery before?
Yes, I did undergo surgery on my right knee few years ago. The thing is, I was a professional football player then, and I had some injury for which for which I was operated, but I don't know the name of the surgery or what procedure I underwent.
Okay, no problem. I'm pretty sorry to hear that. Do you on long-term medication or taking any drugs or allergic to any drug?
No, nothing else. That's all.
Okay. Is there any family member who has the same condition?
No.
Okay. Before I go, can I ask you some personal question, please?
Sure.
What's your occupation?
So I am a football player, but now I work at the club as a coach for the players.
Okay. Do you smoke or drink alcohol?
No.
Do you have any difficulty with the stairs?
No.
Okay. Who is at home with you?
I'm with my mother.
Okay. Before I go further, what do you think is the cause?
It is maybe because of the injury or the operation which I had years ago. I don't know, doctor, what exactly is the cause.
What is your biggest concern?
That it is getting very difficult to play football or run on the field. So that is probably my biggest concern.
Okay, and what do you expect us to do for you?
I expect you to help me get rid of the pain and maybe help me play again.
Okay, I will sure we help you do that.
Can you summarize your history now, please?
Okay, before I summarize, if time would allow me, I would like to ask about the systemic review.
Yes.
This is 28 years old man who presents with right knee pain. Started 3 months ago, started gradually, and he's aching in nature, and he has history of trauma about a couple of years ago, and while he's playing football, and also there is history of swelling and history of surgery couple of years ago, and he's not smoker, no family history, and not drinking alcohol.
All right. So what are your main differential diagnosis? This
My
patient?
first professional diagnosis can be post-traumatic osteoarthritis, or can be due to rheumatic arthritis.
Yes.
And also can be meniscal injury or anterior cruciate ligament injury, and can be due to malignancy.
Okay.
Or
How
can be
would you?
Okay.
How would you confirm your diagnosis?
After checking the history, I will
Yes.
examine the patient first. I also examine the back of the patient and lower limbs.
Yes.
I will order some investigation, routine investigation, CBC, urea electrolyte, and RBG, and also I will ask for first X-ray, anterior posterior with lateral view.
Yes.
Also, you can ask for CT or MRI knee.
What are the treatment options that you can offer to the patient?
First, conservative treatment, encourage exercise and reduce weight, and also physiotherapy. And then for medical treatment, we can offer analgesic like non-steroidal anti-inflammatory drugs or intra-articular steroid therapy. For surgery, can offer osteotomy or arthroscopy or partial or total knee replacement.
Just suppose patient has traumatic osteoarthritis. So what are the cyclical management of treatment which is beneficial, which can be given to the patient?
Cyclical management.
Yes.
Intra-articular steroid.
Before that, yeah. At the end, maybe physiotherapy, oral analgesia, and then yeah, intra-articular steroid.
Okay.
Good. Good. Nice. Thank you.
Thank you.
Yes. Can you give feedback first, Dr. Boyd?
Yes, ma'am. I think, thank you, Dr. Mohammed. He covered almost all the points in the history.
Yes.
Maybe I think he was a little haywire with the this thing of the history, the format of the history, because he asked some questions before and some questions later.
Yeah.
And in the summary also, he covered, I think, every point of
Everything.
the summary. Yes, ma'am. And also in the management, he covered it.
Yeah. Good. And anyone else want to give feedback?
Yeah, ma'am, there is one question.
Yes.
The patient has a very important concern that he wants to play football again.
Yeah.
We need to address this concern.
Yeah. How can that be addressed?
Yes, in the management part, we are going to describe that we are going to sit with the patient and we are going to talk through it. Like, will he be able to play football again? Looks very difficult, but we need some convincing and some sympathy, empathy at that point.
Good. Yes.
Ma'am, but do we mention this without the examiner asking us about the likeliness of him playing football again?
It's patient's concern. You have to
It's a-
address patient concern.
Yeah. But then there are certain, like for history taking station, if it was examination, then okay. But for history taking, they'll mostly ask you diagnosis. How would you rule out or confirm your diagnosis? And then what is the management? So in the management, even if it's a patient's concern, since it's patient's concern, and maybe they can ask you when you think patient will be fit to play again.
Yeah,
So this way they can ask you.
another simple thing is that in a 28-year-old patient who just presents with 3 months of osteoarthritis, saying that we will do total hip replacement, total knee replacement is very something.
This is
something
not.
very-
This is not the 3 months. This pain is now 3 months. Patient has
Yeah.
had previous injury also, and these footballers, they start playing at the age of 6. Maybe
Yes.
this injury was 15 years ago, 20 years ago. So one never knows. I didn't mention it. Even in the exam, it will not be mentioned. But then 28 is quite old age for a footballer.
Yes,
They
ma'am.
happen to retire in this age. So yeah, it's possible. Good. Thank you. Yes, start with your timer and here is your question. Right. So if you have read and understood, considering the surgical pathology station, kindly tell me what are the differential diagnoses that you would consider for this patient?
Yes, ma'am. Considering a short history of redness, tenderness, and swelling, we can put the septic arthritis and osteomyelitis on top. Apart from
Okay.
that, it could be gout or pseudo gout or osteoarthritis.
All right. Okay. Considering it's osteomyelitis, what are the most common organisms that are present or that leads to this condition?
Among the causative organisms, there are gram positives like Staph aureus, Staph epidermidis,
Yes.
Strep pneumoniae, Streptococcus pyogenes, and Strep viridans. Among the gram negative organisms, we have the Enterobacteriaceae, E. coli, Klebsiella, Salmonella, and gram negative cocci like Neisseria and Pseudomonas.
Considering the condition osteomyelitis, what is the pathogenesis behind it?
Yes, ma'am. The infection of the bone can the bacteria can reach the bone through either direct inoculation through a hematogenous pathway or through adjacent soft tissue or joint. And once they reach the bone, there is inflammation of the bone that causes the rise in intraosseous pressure by increased blood flow and exudation. Once the blood flow rises and there is increased intraosseous pressure, it leads to death of the cells and formation of pus. Once this formation of pus occurs, it will lead to drain of the metaphyseal bone into the periosteal space, and this will further devascularize the bone by periosteal expansion of the pus. Once there is devascularization, this will enter into a chronic osteomyelitis phase.
Okay, what are the vessels which are involved in the pathogenesis of hematogenous osteomyelitis?
Yes, most commonly the metaphysis is involved, and it's because of the slow blood flow in the metaphysis due to capillary hairpin lobes that are formed. There is stasis of blood and low oxygen concentration that favors infection in metaphyseal areas.
Right. Right. How the venous sinusoids are formed?
Venous
the-
sinusoids are formed from the distal end. They are as the capillaries are formed from the arterioles, and there is a reverse direction of blood flow from the.
What do you understand by the term involucrum?
Involucrum is the reactionary bone that is formed around the sequestrum, which is the dead bone.
Right. And what are the conditions which can lead to osteomyelitis?
Certain conditions like immunocompromised state or sickle cell anemia can predispose to infection. Other than there's open fracture can cause direct inoculation. And
you mean to say trauma, or give one example of iatrogenic trauma?
yes, if the patient is undergoing fracture surgery or joint replacement surgery, the bacteria can directly be inoculated, and this can cause iatrogenic osteomyelitis.
Kindly give one example of secondary cause of osteomyelitis.
Yes, if the patient is having a pneumonia or any other infection in any part of body, it can lead to hematogenous spread, and this can also lead to osteomyelitis or septic arthritis.
What is sequestra?
Sequestra is the dead bone that is formed by increased intraosseous pressure and devascularization.
Okay. Can you please tell me if there is a pus in the bone, why does it burst out?
It's because the pus has increased colloid osmotic pressure. Yes. And as the bacteria and large molecules are broken down by the enzymes, there is further rise in the osmotic pressure that sucks the water inside. So there is ever expanding amount of pus that causes to seep through any potential pathway it finds, and usually it's the periosteum or the soft tissue facial planes. This is where the pus tracks.
Due to increased osmolarity.
Yes.
Okay. Considering this patient had undergone right knee treatment before 3 years ago, and there was knee plate which was inserted. So how would you go ahead and manage this patient now?
Yes, because the plate will serve as a nidus, and usually
Yes.
the bacteria will form a biofilm on the plate that will negate any antibiotic action. So it is mandatory to remove the plate in order to to completely treat the osteomyelitis in this patient.
After removing the plate, what would you do next?
After removing the plate, we will debride and we will wash and we will give patient antibiotics and the other general care of patients like dehydration and like covering for any dehydration, splinting
If patient fails to respond to antibiotic, what is the next step you'll take?
if there is a fluid collection, we need to drain it. And if there is a
Surgically,
sequestrum formation, yes, we need to remove the sequestra if it's chronic osteomyelitis.
Okay. What is abscess, please?
Abscess is a collection of dead and dying macrophages and bacteria along with the degenerated tissue substance. And it also contains inflammatory mediators. And there is pyogenic membrane that that binds the pus from the surrounding area.
Right. Can you give me example of primary condition which causes abscess, or secondary condition which causes abscess?
Abscess is usually caused by pyogenic organisms, leading mainly the Staph aureus and Staph pyogenes. And these can cause skin infections like impetigo and furuncles and carbuncles.
Yes.
And secondary abscess is formed like already there is something going on, like if there is pancreatic pseudocyst, it can be secondarily infected by bacteria or
Good. Okay, can you please tell me the difference between necrosis and apoptosis?
Yes, apoptosis is programmed cell death that is an energy dependent process. The proteins are specifically made to induce a pathway of apoptosis, whereas necrosis is where the cells cannot compensate for any injury or trauma. There is edema in the cells and rupture of membrane in necrosis.
What are the morphological features of necrosis?
Necrosis is usually liquefative, coagulative, or other features can be present, but there will be loss of tissue architecture, cell architecture. Whereas in apoptosis, there is a physiological process that is used by the body to maintain the size and balance of tissues.
Good, very good.
Thank you, ma'am.
Okay. Right. Cell death, I wanted you to tell me a little bit. Once cell death, if you tell me there are of two types, non-programmed cell death and programmed cell death. If you can give me examples of both, please. Cell death, programmed one is again energy dependent or
yes, programmed independent. Yes. Cell death is a usual process in embryo where clefts are formed or the tubularization takes place in the gut. That is the tubularization of the gut. And the non-programmed cell death is because of the radiation, thermal injury, and loss of blood supply like ischemia. All of them can lead to necrosis. That is non-programmed cell death because of decompensation of the cell physiology and loss of membrane function leading to
not exactly. The two examples of non-programmed cell death is oncosis and necrosis.
Okay.
And then programmed cell death is again divided into Caspase dependent and Caspase independent. Caspase dependent again is of extrinsic apoptosis, intrinsic apoptosis, enochiasis, pyroptosis, cornification. And then the other one also has 5 branches, including mitotic catastrophe.
Yes, ma'am, I haven't read about it. I'm sorry.
These are all in the notes. Good, thank you.
Thank you, ma'am.
I can tell you the page.